So it's actually an ongoing phase 2 trial for patients with a diagnosis of dementia who have trouble recalling or retrieving the names of people that they know well. So we're about halfway through. We're still recruiting for the rest of this year. So we are looking for patients if they want to be involved. That's anybody with a diagnosis of dementia, whether it's Alzheimer's, vascular, or mixed, and a problem naming people that they know well that bothers them. I mean, we all have problems with anomia, which is sort of tip of the tongue type thing where you can't quite get a word that you want. And there seems to be something particularly vulnerable about proper names, people's names. And I think we've all had that experience where you just, go to introduce someone, and even though you know them, you just, their name just won't come. And that's, really embarrassing because it sort of seems to carry with it that you don't know who they are. Tend not to get that for people that we know really well or our family members. But in dementia, some patients, not everybody, of course, gets this for people that they know really well. And it carries the same sort of problem. Relatives or people who know they've got a diagnosis of dementia might think, oh, they don't know me anymore. And that's almost never the case. They don't have problems with facial recognition, or they don't have problems with this sort of semantics. They know who the person is. They know their relationship to them, but they just can't retrieve the name. So and that can be, can affect them a lot, cause a lot of embarrassment. We had one patient who their neighbour, long-term neighbour, they couldn't retrieve their name very frequently, so they were a bit anxious about going outdoors and would check, make sure their neighbour wasn't there before they went out. So the therapy really is something that's other people have published on before. Linda Clare and her team, about 20 years ago now, showed that if you practice on these specific items, so these are obviously individualized to the individual patients, so the people, they would, provide pictures and information about the people that they want to get better at naming, typically sort of first degree relatives or grandchildren. And what Linda Clare and others did was sort of go around to their homes and use a form of fairly classical speech therapy called error reducing learning, where you'd give the patient a few prompts and then do something called spaced retrieval. So you distract them for a little bit and then show them the picture again. And this proved to be effective. So they were much better at recalling the names, perfect. And interestingly, this persisted for at least 6 months, this improvement. All we've done really is wrap it up in an app, of course, because sending someone around to the house is not really practical at scale. So we've wrapped it up into an app. Patients practice at home. Indeed, during COVID, we have had patients who we've never come into UCL, which is where we're running the study, and we've done it all remotely. Sort of post them a tablet which they practice on. So that's it really. We're about halfway through. Some patients have responded very well, of course. Some patients haven't responded at all, but overall currently we're getting significant results of improved spontaneous naming, that is naming without an auditory cue. And this is a bit of a technical point about the construction of the trial, but I work in rehabilitation generally in patients with stroke or acquired brain injury, but we've recently branched out into degenerative disorders because we think that people with degenerative disorders don't get enough in the way of behavioural therapy, and we know that they can respond to it. As with many trials like this, there's a lot of between subject variability, and this has plagued the bigger sort of drug trials that have been ongoing for people with dementia. You get responders and non-responders. So one way around this is to run what are called single case experimental designs, which is where you collect enough data on each individual subject that you can run statistical tests across that subject. You can't do that for all studies, certainly not ones that say require an MRI brain scan at every time point. But you can do it in behavioural studies. Here, our main outcome measure is, so say they come with these 6 people that they want to name, we show them the 6 pictures and they just have to free name them. And that takes around a minute. So we can collect that data quite often. In fact, we collect it every week. So they get into the trial, but they don't get the therapy for the first 6 weeks, but every week we test them. So we sort of establish a baseline, which of course does vary a little bit over that 6-week period. And then they go into a 6-week period where they practice on those 6 names. They do 1 face a day for 6 weeks. And And again, we test them every week. So we have quite a lot of data points before in the sort of pre-therapy phase and then in the therapy phase. And we run some statistics called a Tower U, which looks to see if there are improvements in the therapy phase, but it sort of corrects for any improvement which may happen during the pre-therapy phase, because it's quite possible that just by testing every week, even though they don't get feedback, that they might be improving, and indeed we see that. So with some individuals, we get statistically significant results using this Tau U statistic, about a third of patients. But when you run a sort of more standard, like an ANOVA or a paired t-test, taking the midpoint behavior from the pre-therapy 6 weeks to the post-therapy 6 weeks, we get a group level significance, but that group level significance hides the fact that we've got a mixture of responders and non-responders. But overall, the majority of patients have got a positive slope in the therapy phase compared to the pre-therapy phase, or I should say a steeper slope. So we are also collecting data formally on that. So we're doing qualitative interviews, we're doing semi-structured interviews. Slightly unusually, we're doing a pre-therapy interview and a post-therapy interview. Most qualitative studies will sort of interview participants at the end of the study, but we're also doing a sort of pre-study interview, once participants are enrolled, but before they actually start the therapy. And this is really to work out why people are, especially people with dementia, are getting into studies, and also to try and find out why people turn studies down like this. So we haven't analysed that data yet, so it is really just anecdotal. I think we're finding that people are getting involved for all kinds of reasons. The usual reasons are sort of a hope that this will provide some therapy for people in the future. So a sort of altruistic thing, wanting to do something for other people who have dementia. But also because there is a potential that they may improve. Also, I think to take back a bit of control and feel that they're trying to do something to improve their outcome, which, I think, as I've said, I come from the rehab world where generally we're positive when we come across patients with stroke, for example. We know that they're going to gradually improve with time in the main, even if we don't do anything. And the idea of therapy is to accelerate that improvement and get them to a higher level. But I think in dementia, there's a bit of a negativity about this. You've got a degenerative disorder, your behavior is going to deteriorate gradually over time. And although that's true, you've still got a lot of residual brain capacity, and you can still learn or relearn things. Technically, we're not teaching patients new things, so it's not learning, but it's about reconnecting with neural representations of these linguistic tokens. And that can happen even in quite advanced dementia, as it turns out. So I think it gives some of the patients and their carers, I guess, a feeling of mastery, that they're trying to do something, despite the fact that they've got a degenerative disorder. But yeah, these are really just anecdotal quotes, and we haven't done a formal analysis, but we plan to do thematic analysis when we've got the whole data set. Again, anecdotally, so patients don't always improve by a large number of items. This is something that is an interesting question in the aphasia world in general. Of course, proper name anomia or retrieval is part of a wider aphasic syndrome or problem with language. But within the aphasia world, the question is often, well, how many things do you need to get better at, to make an impact? How many items do you need to improve on? And of course, there is no number. It just depends how important. So some words are more important than others. And we've had one patient who got better just on one name, so it didn't come out statistically significant in that Tau U analysis, so within the single case experimental design analysis that we did. But that one name was her daughter's name, and that made a big difference to her and her daughter. So I think, there are some things that are better captured by a sort of qualitative analysis perhaps than by a quantitative one.